Hi everyone, our research is Crane and motor recovery in stroke survivors, a retrospective case study chart review. I am Zoe.
I'm Natalie.
I'm Andrea.
And I'm Shannon.
Let's introduce our committee members. We have Dr. Fleisley Bao, Professor Hinchinsky, and Nathan from Spectrum Health as our co-investigator. Here is the overview of our presentation. First of all, we're going to give you guys a brief introduction about the stroke background, as well as the motor recovery. Then we're going to talk about problem, purpose, significance, and then we'll go deeper to the literature review about the research funding to support our study. Then we'll give you guys our research question, then introduce our methodology we're going to use for our study. Here's our introduction. So, stroke, as one of the leading causes of the disabilities worldwide, and is also the fifth leading cause of death. Center for Disease Control Center reported that the United States to spend nearly $35 billion each year for the stroke recovery, and it affects 795,000 Americans each year. The stroke recovery patients make up one of the largest population treated by occupational therapists, and the OT use multiple interventions to treat this population. However, it is challenging to find out an evidence-based intervention that tailored to the individuals of the stroke recovery patients. Upper extremity hemiparesis is one of the most common type of impairments after stroke. 50% of patients remains hemiparesis after 6 months after the accident, and 70% of stroke patients are unable to use their affected upper extremity within functional limit even after discharge. Their impairments significantly impact their abilities to engage in their desired activities, and the occupational therapists are aimed to help them to reach the optimal of their ability to perform and engage in everyday occupations. Even though the research is limited, evidence still support that Crane can be used as an effective treatment techniques for motor recovery and improving the motor function for stroke recovery patients. However, it is currently underutilized in the practice. Additional studies are needed to support that Crane can be used to improve the upper extremity motor function for the stroke recovery patients. There are multiple approaches and interventions for the stroke neurorehabilitation, and the mixed evidence has caused to lack of consensus of the best practice in occupational therapy. Crane is one of the anesthetics motor sensory stimulation, has been used effectively for treating the upper motor functioning for stroke recovery patients. Therefore, the purpose of our study is to examine the effect and outcomes of the Crane on upper extremity and motor function in stroke survivors when combined with the traditional neurorehabilitation method in occupational therapy. Here are several significance of our research. First of all, this study can enhance the findings of the research conducted previously. You can provide a better understanding of Crane, and the data can analyze the change in deficits before using the Crane and after applying this to the patients. This research can also advance best practice in OT with stroke survivors in the future study. We will use Ecology of Human Performance, as known as EHP, as our theoretical framework. This includes person, environment, and occupational performance. The stroke patient's tasks diminished in the environment due to their motor and motor sensory deficits, and the decreased task performance produced issues with their occupational engagement and performance. Occupational therapists can help them to improve their skills and abilities to engage their desired occupations by decreasing their deficits and providing a modification to the tasks and the environment. Shannon will talk about the literature review.
In our literature review, we discovered variability in stroke defects, difficulty predicting stroke recovery, and a variety of common occupational therapy rehabilitation techniques. Before I discuss our literature review findings, let me provide some more background information on strokes. The most common defects after a stroke are motor and somatosensory defects. Motor defects refer to any damage on motor skill or movement, while somatosensory defects refer to damage of the sensory system. Motor defects affect more than 80% of stroke survivors. One type of motor defect, hemiparesis, or partial paralysis on one side of the body, is most commonly experienced in the upper extremity. Somatosensory defects have a more variability, affecting 11 to 80% of stroke survivors. The defects of a stroke vary by location, type, number, and severity of the stroke. Studies have shown discrepancies when determining specific defects of a stroke based on the lesion location, which can be in the cortical region or the subcortical region of the brain, and it can also be in the left or right hemisphere. In general, strokes occurring in the cortical region of the brain may disrupt higher cognitive function, produce aphasia, memory impairment, and visual and spatial disorientation, behavior change, and motor weakness or sensory loss. In the subcortical region, strokes may affect movement, coordination, emotion, hemisensory loss, and motor impairments such as diplopia, dysphagia, and nystagmus. Defects in the subcortical region depend more on lesion size, depth, tissue location, and hemisphere. Research has shown more overlap in defects when examining the hemisphere location of strokes, but right strokes will affect the left side of the body and can produce visual problems, while the left-sided strokes affects the right side of the body and can also affect language. The variety of defects of a stroke also affects the ability to predict the recovery of a stroke. We discovered stroke survivors' age, culture, gender, and support system can all affect a patient's ability to recover following a stroke. Research suggests the greatest recovery time for a patient is within the first 3 months following their stroke. This makes early motor recovery addressing a patient's occupational needs essential. Occupational therapists use a variety of rehabilitation techniques to improve functional motor movement in stroke survivors. The most common interventions are repetitive task practice, constraint-induced movement therapy, mirror therapy, mental practice, action observation, neurodevelopment treatment, and somatosensory stimulation. Repetitive task practice involves practicing a specific motor activity. Another approach, mirror therapy, focuses on moving the affected arm while looking in a mirror. This stimulates mirror neurons into thinking the affected arm is moving. 2 semantic reviews conducted by Hatman et al. And Nielsen et al. Found repetitive task training and mirror therapy have been effective for improving upper extremity motor function in stroke survivors. During constraint-induced movement therapy, the therapist constrains the unaffected upper extremity, so the patient has to use their affected extremity. This approach has been associated with limited improvements in motor function, and it is not strong enough to convincingly reduce disability in stroke patients. Mental practice and action observation focus on cognitive rehearsal. They rely on mirror neurons to elicit the desired motor response. A systematic review has found sufficient evidence indicating mental practice may improve upper extremity motor function, but action observation is controversial due to small sample sizes. Neurodevelopment treatment is the most common intervention and has been reported to be used by 80% of occupational therapists. However, only one study has investigated the effectiveness since it was established, resulting in insufficient evidence to improve motor function in the upper extremities. Neurodevelopment treatment is a hands-on approach where the therapist assists the patient to use the affected side of their body. Andrea will now discuss the common somatosensory interventions used by occupational therapists.
So somatosensory stimulation is a different type of intervention strategy. Functional electrical stimulation, also known as FES, is another treatment intervention for stroke patients that is commonly used by occupational therapists. According to Arafage et al. 2017, functional electrical stimulation is an electrical stimulation where electrodes are placed on the skin and low-level electric currents are sent through the body to increase performance of activities of daily living, especially when administered within 2 months following stroke. In various studies conducted by Carrico et al. 2016, Conforto et al. 2002, and Wu et al. 2006, they found that when the peripheral nerves are stimulated through electrical stimulation, the upper extremity of stroke patients had increased movement and sustained that movement 1 month after treatment ceased. Another method of electrical stimulation is transcranial direct current stimulation. A study conducted by Fujimoto et al. 2016 found that stimulating the brain through low levels of electrical stimulation increased tactile performance in stroke patients. Now we will discuss anesthetic somatosensory stimulation. Using an anesthetic produces somatosensory deafferentation, which is the interruption of the afferent connections of nerve cells rather than stimulation of those nerves. Using anesthetics to improve movement in stroke patients is a newer and less common form of stroke rehab. Anesthetic somatosensory deafferentation acts as a numbing agent, blocking sensory information of the affected arm, which results in temporary deafferentation. And temporary deafferentation reduces the excitatory neural inputs to the somatosensory cortex. A eutectic mixture of local anesthetics, also known as EMLA cream, has been found to increase movements in the paretic extremity of stroke patients. The procedure includes administration of the cream 30 minutes prior to a standard 45 to 60-minute occupational therapy session. According to Lowell 2004 and Sens et al. 2012, EMLA cream has been found to increase the motor and sensory function of stroke patients' affected side by applying the cream to both the affected and non-affected side. According to Opsimer et al. 2006 and Bjorkman et al. 2004, EMLA cream does not impact the somatosensation of muscles in deeper tissues, but can have a longer lasting effect than electrical stimulation shown through increased perception of touch for at least 24 hours after the cream was applied. So now Shannon will be talking about the assessments.
Vogelmeyer assessment is considered the gold standard assessment, measuring single and multi-joint movements, out-of-synergy movements, digit individualization, movement speed, dysmetria, ataxia, and reflexes. This is considered the gold standard for stroke rehabilitation because it measures so many different motor functions and movements and produces a final score. These scores can be broken down into different joints or can be combined together. Research has proven that FMA scores will improve approximately 70% after the original FMA score is recorded. The original FMA score must be recorded within the first week following the stroke. The percentage is calculated by taking the difference between the maximum upper extremity FMA score and the initial score received. Although the FMA score can predict the patient's motor function following therapy, the recovery of a stroke will still vary. Other assessments used to measure motor function following a stroke include manual muscle testing, boxed and blocks test, and a 9-peg hole test. Growing evidence supports the importance of somatosensory de-efferation with stroke survivors. However, occupational therapists have reported barriers to implementing somatosensory treatment into practice, including time constraints, large caseloads, and lack of access to somatosensory assessments and treatment resources. Our findings from our literature reviews show discrepancies in the strongest occupational therapy interventions to improve upper extremity motor function following a stroke. Amla cream has been proven effective to increase motor function in stroke survivors. However, the long-term effects have not been investigated. This study will provide a better understanding of the effects of Amla cream to grow the body of evidence around an under-researched technique to further develop neurorehabilitation techniques used in occupational therapy practice for stroke survivors. Additionally, this study will aid in the development of further research to create new neurorehabilitation techniques. Now, Andrea will explain our research question and our hypothesis for our research.
So our research question is, what are the changes in assessment score results taken upon initial evaluation and discharge of stroke survivors receiving Amla cream and traditional occupational therapy rehabilitative interventions? And our hypothesis is that Amla cream will show improved upper extremity motor function recovery when combined with traditional neurorehabilitation occupational therapy techniques. So now Natalie will talk about our methods.
The design we will be using for this study is a retrospective case series chart review design. This kind of design allows researchers to investigate existing data and determine if associations exist between individual cases. In the present study, we will be examining pre- and post-assessment scores for the FMA, box and blocks, 9-hole peg test, a sensation screen, and grip strength in the medical records of patients that received Amla cream in conjunction with traditional neurorehabilitation techniques. Research has shown that using explicit protocols for data extraction increases inter-rater reliability during retrospective chart review studies. However, that is not a concern for our study because our Nathan will be the only person extracting data for us. Inter-rater reliability refers to reliability of data collected by the same person on 2 or more occasions. Again, this will not be a concern because Nathan will be only collecting our data one time. Inter-rater reliability is related to clinical competence. So when researchers have experience and competence in a clinical setting, which Nathan does, inter-rater reliability increases. In medical charts, physical findings, diagnoses, and lab findings tend to have high reliability and validity compared to more subjective measures like patient complaints, so we can assume that our assessment scores have a reasonable amount of reliability and validity. Literature suggests that data to be extracted should be reviewed by experts to ensure that the area of interest is being fully represented. In our case, we have done this with our committee to ensure high content validity. That said, reliability and validity can be affected with incomplete or missing data, which we cannot predict at this time. So we are assuming that the data accurately reflect what happened. For our population and sample, we will be investigating stroke survivors from an inpatient unit at Lakeland Spectrum Health in Watervliet that received EMLA cream in conjunction with traditional neurorehabilitation techniques. No subjects will be recruited because we are using existing medical data. Our sample will be a convenient sample of those that meet the following inclusion criteria at the time of initial evaluation. Patients must have had an FMA score between 25 and 50, manual muscle test scores for active digit and wrist flexion at most 3- out of 5. They must have been younger than 80 years at the onset of stroke, and they must have received a diagnostic ICD-10 code between 163 and 163.9. Lastly, these patients will have received EMLA cream in conjunction with traditional neurorehabilitation techniques within the last 3 years, from January 1st, 2017 to March 31st, 2020. So for our procedures, we will be reviewing medical charts of patients. Nathan will be reviewing the medical charts for us to protect patient privacy. The data to be extracted will include age, sex, race, diagnosis, length of stay, and the frequency of EMLA cream application, in addition to pre- and post-assessment scores for the FMA, MMT, 9-hole peg test, box and blocks, sensation screen, and grip strength. Lastly, these data will then be de-identified by Nathan. The de-identified data will then be organized into an Excel spreadsheet. This spreadsheet will be downloaded onto an encrypted portable storage device, which will then be by Nathan, which will then be delivered to our principal investigator, Professor Hachinsky. She will deliver the device to us for data analysis, and when it is not in use, it will be in a locked storage unit that is research specific at Grand Valley State University. To analyze our data, we will be using SPSS 25. We will be investigating descriptive statistics for the pre- and post-assessment scores across all patients. This includes minimum and maximum values, mean, median, and standard deviation. Descriptive statistics will also be analyzed for the change in scores for each assessment across all patients. So, for example, we will be taking descriptive statistics for all pre-FMA scores and all post-FMA scores separately across all patients, and then we will analyze descriptive statistics for the difference in scores across all patients. So that number would be the change from pre to post. Like all research designs, ours is not without strengths and limitations. Two significant strengths of this study are its time and cost effectiveness due to using existing data. Additionally, it will allow us to investigate a rare occurrence such as the use of EMLA cream in occupational therapy. Lastly, it generates hypotheses for future prospective studies, so this study can lay the groundwork for more complex prospective studies in the future. A significant limitation of this study is that we are heavily relying on the availability and accuracy of existing medical data. Since it is uncontrolled, we are not able to measure bias or confounding variables that may have been present at the time of data collection. Since there is no control or random assignment, we will not be able to definitively determine a causal relationship in our study. Since there is no control group of those that only received traditional neurorehabilitation techniques, we will not be able to say if changes in assessment scores between those that received EMLA and traditional neurorehabilitation will be more significant than those that only received neurorehabilitation. However, this opens the door for continuing research with a case control study in the future that does utilize a control group of those that only received traditional neurorehabilitation techniques. So we are providing an opportunity to continue the line of inquiry. Here are all of our references. Thank you all so much for watching, and we are looking forward to discussing this with you soon.